of substance is extends, and the borders cannot be approximated. This is the case of an ulcer, a pressure ulcer, which is a big hole with loss of substance, or can be the case of a burn. Yes, so those are examples of wounds that require little by little, along weeks and maybe months, a granulation tissue to be growing from the bottom to the top. And when the granulation tissue reaches the top, the epithelium will grow over the granulation tissue, closing the wound. Obviously, it will take a long time, much, much longer than the primary intention. And the scar will be much, much wider, much, much, evident, much more prominent. This is the example of secondary intention healing. No problem. So, and then we have a possibility. I don't know how clear are good, for example, with compartment syndrome. In compartment syndrome, we have in one extremities, let's imagine that it is in the leg. Okay, we have a trauma, maybe we have a fracture, and this fracture is going to produce a severe edema and hematoma that is compromising the blood flow through the artery that should go from proximal to distal, no? So the artery is going to be compressed, is going to be strangled, and the blood is not passing. So there is not blood flow there. This is compartment syndrome. Okay, in compartment syndrome, doctors will open a wound with an scalpel and under anesthesia along the legs. You'll see how these borders will separate because there is a lot of swelling of edema inside the leg that is the one that is producing the compression. And this leg must be left with this open linear surgical wound is left open along many days until the swelling and the hematoma is reabsorbed and is not compressing anymore the artery. Of course, when they open the leg this way, the pressure is relieved and then the blood can flow again and the extremity is saved. When the swelling disappears and it is possible to approximate the borders of the wound again, the doctor will approximate the border because the swelling has already subsided, will put stitches, will, include stitches, and the wound will be closed. So there is a postponed, a delayed closure days after the incision is open, waiting for the edema, the infection, or whatever requires a delay in the closure of the wound happens. So fasciotomy is an example of tertiary or delay or postpone closure of the incision. Also, when we have a laceration, but it's very contaminated, there is a lot of contamination inside, doctors can leave the laceration open for days while the antibiotics and the cleansing process, the irrigation, cleans the wound, and then when it's already controlled the infection, then they close, they approximate the border with stitches. So it's the same as the primary intention, but delayed until the moment is appropriate. So I hope that you understand the difference between the three and you can use examples of each one in case it is tested. Eczema is frequent in English because eczema, atopic eczema or atopic dermatitis is very frequent. Is an allergic condition that frequently associated with asthma, allergic rhinitis, etc. And there is increment of eosinophils, immune globulin E, as on any allergic condition. You know that those allergic tendencies are genetically predetermined, is a predisposition. You can see that since childhood, and the issue is that this eczema produces a lot of itching or pruritus, and the child has not control, will scratch frequently, continuously their skin, producing a skin breakdown that overcome infected. For that reason, it's super important to keep the nails shut, keep the hands clean, and to cover the hands, especially at night, with gloves to prevent the scratching. The skin of people with atopic eczema is extremely dry, so doctors will prescribe moisturizing, okay, lotion, medicated lotion, and will recommend avoidance of chemicals in the skin like alcohol, like body powder, like lotions that have not been prescribed, like bubble bath, etc. Clothing, uh, um, like for example, wool, latex, and synthetic, those kind of fabrics that are synthetic are going to be also aggressive for the skin of client with this condition and should be avoided. Psoriasis is a condition in the skin which is considered autoimmune. As most autoimmune diseases, we don't know why it happens, but we know that there are cellular and humoral immunity. I mean, white blood cells and antibodies that are confused and attack the skin as if the skin were, a foreign substance or bacteria. Sometimes this autoimmune attack can extend to the joints. So with certain frequency, clients with psoriasis also suffer of psoriatic arthritis. This arthritis is deforming and is very similar to the rheumatoid arthritis. So it is a serious condition. As most of the autoimmune disease, psychological stress exacerbates the condition. And a classical question in NCLEX is when to expect a flares up of a psoriasis as any other autoimmune disease, and then you need to choose a condition that could be producing stress in the client. Paradoxically, sunlight, okay, the sunlight is beneficial for those clients. We know that we should avoid excessive sunlight because the risk of skin cancer, but in that case, in the case of psoriasis, occasional exposition to sunlight is beneficial, will produce improvement. As a matter of fact, there is a therapy, a medical therapy called ultraviolet A therapy, or PUVA, solar ultraviolet A therapy is what means the acronym PUVA, in which they use special chambers. Those are not tanning chambers, okay? Tanning beds. No, 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 no. Tanning beds is bad for the skin, produces aging and cancer. It is a medical control type of ultraviolet therapy, okay? And immune suppressors are frequently used in the treatment of this disease. So don't be surprised the clients prescribe methotrexate and immune suppressors, adalimumab, and etanercept that are also biological modifiers that work as immune suppressors. Skin cancer is a priority in Nclex, but of all the possible skin cancer, the malignant melanoma is the most feared and the one that Nclex insists the most that nurses, general nurses, should suspect the possibility of having a case of malignant melanoma and referring the client to be evaluated by the doctor. Doctor will practice a biopsy in the lesion that is suspicious and will confirm if it is or not a skin cancer. For the clinical diagnose through observation of possible malignant skin lesions or moles, we use the ABCDE rule, and this is what is tested in NCLEX. In that picture that I have here at the top, we have a malignant lesion, a malignant or suspicious mole. In the inferior, we have a benign mole. So A stands for asymmetry. If we draw an imaginary line dividing in two parts the lesion, we'll notice that one half is totally different from the other half in case of malignancy. Asymmetry, in contrast with the benign lesion that each side is a mirror image of the other side, is a very symmetrical lesion. This is what means the A of asymmetry. The borders of malignant lesions are very irregular, very rag, look like geographic, like a map, yes? While the borders of benign lesions are sharp, well delimited, okay, are not at all irregular. This is the B of border, the difference between benign and malignant lesions. The C stands for the color. It's not important which color it is. Can be brown, can be black, can be red, can be white, can be any color. But the important is the way that the color is spreaded or distributed in the lesion. As you notice in this malignant lesion, the color is distributed very irregularly. Here is dark, okay, brown. Here has like a pink hue. Here has like a greenish, okay, coloration. There are different degrees of darkness of the brown color. Here, the color is uniform, is even, is the same color all over the lesion. That's what means the C of color. D stands for diameter. It's accepted that any diameter of a mole measuring more than 6 millimeters should be evaluated by the doctor. And E stands for enlargement or elevation. I mean growth. A lesion that is rapidly growing has also a criteria of malignancy. Remember that the relation with skin cancer with sunlight is very tight. So we need to recommend for people with fair skin or people with family history of melanoma, malignant melanoma or skin cancer to protect their exposed skin with solar protection factors more than 15, preferably 30, and to avoid the sunlight between 9 a.m. and 4 p.m. Between 9 a.m. and 4 p.m., the sunlight is very intense and you should avoid going out in this period of time. And if you need to do that, use sun protector, long sleeve, umbrella, a wide brim hat, etc. Acne. Uh, I don't think that acne would be a question in your ankles, except when it is talking about the medication isotretinoin. Acne is a very common condition in young people, sometimes extend to middle age, because hormonal disbalances that increase the production of sebum by the skin. There are bacteria of the normal flora of the skin that eat those sebums, producing byproducts that produce inflammation in the skin, in the pores, and then you have those blackheads, papules, and pustules that are the lesion of acne. The experts say that diet has not an important role or influence in acne. That those those concepts that people have about the diet producing acne are not sustained by evidence. A healthy diet, but without a specific limitation, is okay. There are different treatments like exfoliating, like benzoyl peroxide, acylic acid, etc. There are topical antibiotics to decrease the normal flora of the skin. Even systemic antibiotics, the most commonly used are the tetracyclines. Doxycycline is the most common used tetracycline. Remember that there is a lot of photosensitivity in clients taking tetracyclines. Should avoid the sunlight. But the most effective treatment for severe acne is the isotretinoin. Isotretinoin is a substance derived from the vitamin A. But this medication is highly teratogenic. So any young woman in childbearing age that is prescribed isotretinoin, first pregnancy test should be practiced to rule out pregnancy. And after that, prevention of pregnancy must occur. Meanwhile, is taking the isotretinoin. Two different contraceptives should be used at the same time. One is hormonal, the other is a barrier, and should be maintained until 3 months after discontinuing the medication to allow the patient to become pregnant. Because this is a derivative of the vitamin A, the client should avoid taking over-the-counter vitamin A supplements because they can produce toxicity. Vitamin A can produce toxicity. There is a skin condition that can extend to deeper parts of the body, including the nervous system, called neurofibromatosis, that has been commonly in English. And just for that reason, I want to mention this condition. This is a hereditary condition, so it's a pass through the genes from parents to children, but sometimes there is a new appearance, it's a new mutation, have different level of severity. This is not nursing business, but what is important that since birth, we can suspect the condition because the client presents multiple big, not small, big, okay, much more than 1 inch size, cafe au lait or coffee and milk, okay, brown, coffee, like coffee and milk, like cortadito, okay, cafe au lait, okay, spots, multiple and big, since birth, and this is what is tested in NCLEX. If you see a newborn with multiple spots, multiple moles, cafe au lait, okay, you need to report that to the doctor because in the future, benign tumors of the nerves can produce called neurofibromas. That's it. This is what you need to know, nothing else. From the point of view of nursing, it is the only thing that you need to know. Burns is very commonly tested in English. You know that in burns, the priority is going to be ABC. Airway and breathing is going to be the absolute priority in burns. This is a priority if the burn occurs in the upper part of the body. So when burns occurs in the head, face, or neck and upper chest is when the burn of the airway can happen. Understand that to have a burn the face of the head, you need to have for some moments, you need to have some period of time, you need to have flames in front of your face. And of course, the person needs to continue breathing even if it is in the middle of flames, yes, fire. And the heat of the flames can penetrate in the airway. And remember that airway is all this whole, this communication that exists from the mouth and the nose, vocal and nasal cavity, pharynx, and the entrance of the trachea. Here I have a picture at the left of a normal entrance of the trachea. So notice that it is a hole here, and this is the hole that is going to be normally open to allow the air to come and live. Even we can see here the vocal cord. This structure here is the epiglottis, yes, but all those tissues are soft, and in presence of heat, they become swollen. Okay, burns and heat produce vasodilation, leak of liquid in the interstitial space, and swelling. So this hole that should be this size will become this size or totally absent. So obviously is the A of ABCs. The burns can continue deeper to the bronchi and alveoli, and then we can have pulmonary edema. Obviously, a client that have a burn in this area will have hoarseness, and the voice will be, different than normal. Will have probably a stridor, will probably have cough, a dry cough because the irritation in the area, and even could be spitting up, soot, could be spitting of charcoal of the flames and the 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 substances that were burning in his or her presence. Any burn, any burn in the face, including discrete burns like having burned the mustache, the beard in males, nasal hairs, eyebrows, and eyelashes should make you suspect that the airway could be burned. That's why a client that was in a fire that has a cinch, nasal hair or facial hair becomes the first client to see, because you are not going to wait until the airway is in this critical state to act, to activate the doctors that should be taking care of the airway of this client. Notice this client with facial burns, how had to be intubated through the nose because the mouth was so swollen that couldn't be intubated. Now a tube is keeping this entrance open, and then the doctor with comfort in a secure way can do a tracheostomy in this case to provide um, artificial ventilation. When a client has a burn after this airway and breathing situation, the next is going to be the circulation. The burns usually produce a leak syndrome, a capillary leak syndrome that makes the bulimia, the water of the blood, spill in the interstitial space. That's why the swelling, you understand? Why this extreme swelling that you see there? This swelling will occur in any part of the body that has been burned. It's not only in the face. So what is happening there? The water that should be in the blood inside the capillary, inside the veins and the artery, is going to be translocated, is going to be shifted to the interstitial space. What is the consequence of this? First, edema, that in some parts, as we just explained, can be life-threatening because this edema of the airway will produce obstruction of the airway. But the other consequence is that the blood is going to be left dry. I mean, you are going to have an acute hypovolemia, an acute for a volume deficit, fluid volume deficit, because the water is moving from the blood, where it should be, to the interstitial space, where it's not participating in the circulation. So this client will start presenting the syndrome of fluid volume deficit, characterized by hypotension, activation of the sympathetic nervous system with tachycardia and vasoconstriction, decreased urinary output because activation of the antidiuretic hormone, etc., etc. This condition will evolve until hypovolemic shock, and then the hypovolemic shock is able to kill the client. So this is the B of ABC, sorry, the C of ABCs in the case of this client. It's important that to calculate how severe is the burn and how intense this capillary leak syndrome will be, and how much liquid needs to be replaced in this client, you need to have an idea of calculating the body surface area that has been burned, because it's what we will use together with the weight of the client to calculate how much liquid is required. For that purpose, I suggest you to divide the body in head, extremities, and trunk, remembering that the head and the upper extremities are relatively small, because the head and the upper extremities are small, will allocate only 9% of the body surface area for each one of this area. So 9% for the head, 9% for the left upper extremity, 9% for the right upper extremities, or right and left. Okay, so 9, 9, and 9. The lower extremities are, of course, bigger, much, much bigger than the head and the upper extremity. So please allocate, okay, assignate 2 nines, I mean 18. 19 times 2 is 18. So 2 nines to the lower extremities and to each one. And then the surface of the trunk is huge in comparison with all the rest of the body. So you are going to assign to the trunk 4 nines. 4 times 9 is 36, yes? So 36% to the trunk. Of course, the human body is not flat, is not in 2 dimensions, it's tridimensional. For that reason, you need to distribute those nines, those percentages around the part of the body. So if you have, for example, burns only the anterior part of the head, please give the half of 9, which is 4.5, an example. If, for example, you have burns only the anterior part of one leg, give only 1 9. Only 1 9. Don't give the 2 9 because the posterior part is spared. The same for the trunk. The anterior is going to be 18, I mean 2 9s, and 2 9 for the back, etc., etc. Don't forget that the perineal area and the genital is assigned 1%. If you add, okay, the percentage of all the body, you'll notice that it is 99. If you add 9 plus 3 nines is 27, plus 18 plus 36, you have 99. So the 1% that is missing is for the genitals. Don't forget that, okay? So it depends if you prefer to memorize 9, 9, 9, 18, 18, okay, 36, and then just spread front and back, or you do as I prefer to do, 1, 9 for each one of the extremities, 2 for the lower extremities, and 4 for the trunk. It's up to you. Take care, because sometimes there are more precise ways of calculating. This is the preferred rule. It's called the rule of nines, because can be quickly done in the ER when the clients arrive. But in NCLEX, I've been informed that they are being discriminating in the head, the neck from the head. Okay, being the neck 1% in each side, so in total 2%, no? 1% in the front, 1% in the back, 2% for the neck 2%, and then the remaining 7%, 7% for the rest of the head. Okay, 7 plus 2, 9. Yes, it's the same 9. But then you discriminate 7 for the head without the neck and 2 for the neck. If it is 7 for the head, it is going to be 3.5 for the front, 3.5 for the back. If you add that, it is 7. If it is the neck, 2%, it is going to be 1% from the front, 1% from the back, okay? So please have this detail in mind, because I've been informed that they say the client has burn of all the anterior part of the trunk. So you say, okay, this is 18. And burn of all the right upper extremity. You say, okay, it is 9. And burn of all the anterior part of the head, but not the neck. So you need to add 3.5. Because if they say not the neck, you need to use this discrimination, this separation between head and neck, in which head is 7 and neck is 2. Makes sense? So if only the anterior part of the head, sparing the neck, is burned, the head is 7, but only the anterior part have 7, 3.5. Yes? And then you add, and you are going to have exactly the number that they want to choose. Is okay? Everybody understood this detail? Okay, so have that in mind,
Yes,
because
yes.
having repetitive this detail, and it's confusing for us, because usually what we learn is all the head and neck is 9, but English is making this separation between head and neck,
That,
which is very easy.
yeah, that's true.
Okay, this is based in what use the doctors in the burn unit. That is a much more detailed, but you don't need to learn that. You don't need to learn all those the other detailed separation. Only please, based in what has been tested in anchors, the separation between head and neck. No problem with that. Okay, the depth of the berm is also important for the understanding of the depth of the burns. I like you to refresh your anatomy and physiology. Remember that the skin is only this part, okay? This part is the skin represented by the epidermis, which is here the green line, and the dermis, which is the pink, online. This is the skin. The skin in the dermis, we have, okay, capillaries, tiny capillaries, yes, and we have nerve terminals, okay, so we can feel the heat, the cold, the vibration, the pressure, the pain, etc., in the skin because we have nerve terminals in the skin. Under the skin, what you have is the adipose tissue that make the subcutaneous tissue. So under the skin, subcutaneous. Subcutaneous is characterized by made mainly by fat. Fat has few blood vessels. So that's why when we make a subcutaneous shot injection, the medication will be absorbed slowly. Why? Because the subcutaneous have little amount of blood vessels. And then beyond the subcutaneous, we have the muscle layer. And the muscle layer is surrounded by a fibrous tissue called fascia. Yeah. Under the muscle, usually we have bone. So those are the layers of the soft tissues that are over the bone. It's important to remember this anatomy to be able to understand not only the depth of the burns, but the pressure ulcers classification. When we have a burn, we have three levels of burns. Nclex one, only three levels. Don't complicate. Makes it only three levels. Okay, the superficial, the partial thickness, and the full thickness. Yes. The superficial never is tested because it is a sunburn. Yeah, it is a sunburn, erythema and burning sensation, and that's it. It's going to heal spontaneously without treatment. Then comes the partial thickness. In partial thickness burn, only part, the most superficial part of the skin is damaged, is burned. So I represented here part, only part of the dermis, and of course all the epidermis of this burn with those dark dots as the part of the skin that is killed, is damaged, is yes, killed by the thermal injury. The deep dermis is not affected, only part, partial. That's why it's called partial thickness. It's not full thickness, it's only part, the most superficial part of the dermis of the skin, the one that has been damaged. As a consequence of this death of the part of the skin separates, the dead skin separates from the alive or healthy skin, and a cavity forms that is quickly filled with liquid that is coming from the interstitial space and the blood vessels. Is a serous, okay, liquid. This structure, this uh, ceiling, this roof made by the dead skin and the liquid in the cavity is called blister. So blisters are the sign, the classical, the characteristic visible sign of a partial thickness burn. Blisters, partial thickness. Blister presence, partial thickness. By the way, those burns are very painful because the nerve terminal are exposed, and that's why are very painful. This lesion, nurses don't break the blister, but doctors later, under sterile circumstances and under sedation or anesthesia, they are going to eliminate this dead skin, and then they are going to cover the exposed dermis with a type of dressing that protects the moisture and prevents infection. Some topical antibiotics are used, like the silver sulfadiazine to prevent infections, but there is not there is not indication. They don't use antibiotics. They use topical, apply topical in the wound of antiseptic uh, creams and cover with bulky, sterile dressing to protect this dermis from becoming infected and becoming desiccated, but there is no need of systemic antibiotics. Take care because it was tested in Nclex. There is not indication of giving antibiotics before infections occurs, and there is no need of infection for occurring. So this is the treatment of these superficial um, burns. The dermis that is left alive in the bottom will reproduce the remaining needed dermis and the epidermis, and this wound will heal soon with adequate care, which I already mentioned, must be covered all time, and without a minimum scarring. There is no need of any graft or transplant because the own client skin remaining skin can be enough to reproduce the loss of skin. Remember that those burns are wounds that are predisposed for tetanus, so boosters of the tetanus shot should be given. And because the pain management is very important. So remember that we need to be aware that each time the client go to wound care, needs to have okay analgesics with anticipation to the to the to the the wound care. The full thickness is the last level. By the way, this level of burns in the past were called second degree. You remember? Okay, the full thickness or third degree, as they were called before, all the skin is gone. So all the skin is burned. All the skin is burned. There is no skin left alive because there is not skin left alive. There are not blood vessels. All the blood vessels, the word here that could produce the liquid, the blister, were burns, were cauterized by the burns. So you don't have blisters in the full thickness of burns. There is a totally charred, totally burned skin, and because it's burns, it's like fried, is like a pork rind. It's like a chicharrón. You know? There is not a blister there. There is no moisture there. It's a dry, leathery, uh, tough eschar in the skin. Usually tan without coloration or dark brown or black. It is dead skin. These kind of burns can extend to the subcutaneous and even to the muscle, depending on the time of exposure to the thermal injury. It also can be seen so deep in electrical burns. Understand that if the depth is extensive and includes the muscle, we can have a much more serious situation because there is a massive, catastrophic death of cells. And remember that those cells contains inside a lot of potassium. Remember that inside the cell, the potassium can be as high as 150 milliequivalents per liter. So now all this intracellular potassium is a spill of the destroyed cells, is a spill into the circulation where the potassium cannot be beyond 5. So you can have hyperkalemia in an important burn. The other is that if the
Professor,
yes, man, yes,
sorry. In this case, when the patient is hyperkalemic, when you administer lateral ringer
no,
that have
it's contraindicated.
oh,
Ringer lactated has potassium and is the preferred isotonic fluid in regular, normal, usual majority burns. But if the client has hyperkalemia or has renal failure, Ringer lactate is contraindicated because Ringer lactate has potassium. It is an Nclex question, by the way. So Ringer lactate is wonderful. It's very good for burns. We continue preferring, sorry, Ringer lactate for burns, but if it is the severe burn that, as I mentioned before, that could produce hyperkalemia, then Ringer lactate is contraindicated. Is preferred the normal saline. Why? Because Ringer lactate includes potassium, a part of lactated potassium. Are we good?
Thank you, Professor. Thank
My,
you.
my pleasure. When the muscle is also burns in those, severe deep burns, the myoglobin, which is the protein that should be inside the muscle cells, can be spilled into the circulation and can end in the kidneys and in the urine, producing what is called myoglobinuria. The problem of the myoglobinuria is that this protein clog the tubules of the kidneys and can produce acute renal failure. The myoglobin can be detected in the urine in lab tests, but it's going to confer a reddish brown color to the urine that should make you suspect this complication. The burns that are full thickness, the doctor need to remove this dead tissue, of course, under anesthesia and sterile conditions, and then a granulation process must occur. And when there is an adequate bed of granulation tissue, doctor must take skin from another part of the body that has not been burned and move pieces of those skin here to make the skin grow over the granulation tissue. What is used is the skin of the own client. Meanwhile, the process of healing occurs, the granulation, a skin of animals or even a skin of cadavers can be used to cover the wound and promote the healing. But this is not going to be the permanent, okay, skin that is going to grow later. They need to take a skin of the own client from a spare part of the body and to make a skin graft that requires a lot of specialty and care. And because it is a specialty, I think it is beyond the entry level generalist nurse to know the details of the skin graft and the care of the skin graft. But the emergency care of the burns is in the scope of entry-level nurses, and the most common test is the ABCs of the immediately burned client, that as we discussed before. But we were to talk a little more about the circulation and the capillary leak syndrome. And you know that for this hypovolemia, we calculate a volume of liquid with the Parkland formula. The experience that I have with anchors is that they don't make you calculate the Parkland formula. They give you the Parkland formula already calculated. But just in case, it is very easy. The Parkland formula has three components. One is a constant. Constant is a number that doesn't change. It's constant, like P, 3.1416 P, you know the value of P? Okay, this is a constant. It is 4. The constant is 4 for all the clients. The other element of the formula is the weight in kilos of the client. It is variable. This is different size of clients. And the other variable is the body surface area that has been burned that you can calculate with the rule of 9s. And when you multiply these three elements, you have a number. Usually is a number in the order of the thousands, yes? And this is the volume in milliliters, cc milliliters of liquid that must be administered in the 24 hours after the burn, starting immediately after the moment of the burn 24 hours are calculated in liquid. And what is, as I said before, they give you already the calculation. They say, oh, the client was a Parkland formula calculation of 5,000 milliliters. How you administer this liquid. So you need to know that half this volume, half this volume calculated with this formula must be passed in the first 8 hours. And the other half in the remaining 16 hours. You know that the day has 24 hours. So 8 plus 16 is 24, yes? So the first 8 hours have the volume. The other half, the remaining half in the remaining 16 hours, which is the same as saying 1/4 of the volume in the second and third 8 hours, because you know the 24 hours have 3/8. 1/8, second 8, third 8. Yes, that makes 24. In the first 8 hours, half the volume. In these 8 hours, 1/4 of the volume. In these other 8 hours, the other fourth of the volume, which is, of course, 1/2 that to be passed in these 16 hours. Is the same. Don't make it difficult, because it's the same. You can understand that perfectly. And this is what it,
Professor,
yes, man.
that's the number you got. You divided by two.
Okay, so if they give you 5,000 milliliters to pass in 24 hours, and they say half, those are $5,000. So we need to divide that between you and me in equal parts. So how much money I need to give you?
2,500.
Exactly, 2,500. But this 2,500, this half is to be passed in the first eight
8 hours.
hours.
Okay.
Yes, but
Yes.
in reality, it's not 2,500 for me, 2,500 for you. The other 2,500s are also belonging to the client, but are going to be passed in 16 hours. Which is the same as saying, okay, okay, you can say 2,500 in the remaining 16 hours, or you can say half this is 250 is 1,250 in 8 hours, and 100 and 2,050 in the other 8 hours. So you can make any combination. So for example, let's see a question that I have here. A question that I have here. Okay. So you can see how you need to use this evident or simple rule. No? Uh, no, this is not the question you can. Okay, suppose I'm going to make a question for you. The client has been calculated the Parkland formula, 5,000 milliliters, the same number that I say. Okay, and the client was burned at 8 a.m. Okay, um, in the first 8 hours, so at 16, okay, at 16, this is 8, 16, you need to pass half, no? In this period, you need to pass half. So at 16 hours, 2,500 should have passed. I can ask you, at what rate, at what rate you set the pump at 17 hours. So 17 hours is after 16, yes, because is if you have the berms at 8 using military hours, 8 plus 8, 16. So in this interval, the client will be receiving 2,500 divided by 8. How much is it? 3 por 8, 24. 300 sobre una. 350. 350, I think. No, 325. Okay, whatever it is, I would make a calculator. I don't have a calculator available. 25 divided by 8 divided by 8.
How much is
Uh, uh,
12?
313.
Divided by
313, because you need to round. 313. Yes? 313 milliliters per hour. What I did, this is a liquid that needs to be passed with a pump. You cannot pass that without a pump. You need to have very exact, regulation of the volume of liquid to pass. You need to pass 25,000, okay, 2,500, sorry, milliliters. 2,500 milliliters in how much? In 8 hours. How you set the pump? Very simple. It's a simple formula you should know. It's the volume divided by the time in hours. So divide 2,500 divided by 8, the value is 313. 312.5, you round, 313 milliliters per hour. This was the pump in the first 8 hours, but they asking me how I will set the pump, okay, how I will set the pump in the hour 17. So after the next period of time. So you know that the other half, the other 2,500 milliliters need to pass in how much? In 16 hours. Yes, in 16 hours. So when you divide 2,500 divided by 16, you have 156 milliliters per hour. Okay, be honest. Any one of you want me to repeat that?
No.
No?
no, no, that's
Everybody is
okay. Thank
okay?
you. Yeah,
Because
I'm okay.
this
Thank you.
is this is the way that is tested in English.
Okay, thank you.
This is the way that is tested in English, okay? The Parkland formula. So don't waste your time memorizing the Parkland formula, even if it's so easy to memorize. But the question that I've been, observing in English is the practical approach, the role of the nurse. That is, while the doctor calculate the Parkland formula and orders the amount of liquid to pass, is the nurse the one that need to make the calculation to know the number that need to be introduced in the pump to set the pump to pass the liquid in the order time. You understand? And so NCLEX is nursing, is not physician, is not medical test, is nursing test. And those are the questions that I think about that. Independently of how well the Parkland formula has been calculated and how well you set the pump, you need to verify that the client is receiving the adequate amount of liquid. That's why it's so important in the first 24 hours to measure the hourly urinary output of the client that you know should be above 30 milliliters per hour if the amount of liquid is the adequate. Clients that have burns are at high risk of acute renal failure for hypovolemia, for myoglobinuria, etc., hypotension, etc., etc., even for medications. So we need to be very careful of keeping the client well hydrated with the adequate amount of liquid to prevent this acute renal failure. Don't forget an important issue in burns. Burns clients frequently are in extreme stress. First, because the pain, the psychological environment of the burns, the trauma of the burns, but then the physiological stress is a severe tissue damage, extensive tissue damage. All those physiological and psychological stress predispose the client for acute gastric ulcers that tend to be multiple, deep, and very bleedy. So the clients can start vomiting blood, can have an upper GI bleeding hours after the burns. it is a form of a stress ulcer called curling. Okay, a guy called curling. Okay, named those ulcer after him, and should be prevented with protoporphyrin inhibitors. That's why it's a protocol to give protoporphyrin inhibitors. Also, clients with extensive burns frequently have ileus paralyticus. You know that it is the paralysis of the intestine, the absence of bowel sounds and passing gas, and for that reason, the oral route tends to be limited in severe burns, especially in the first days of the burns. There are variations of burns, like for example, the electrical burns that tend to be very deep, but this is not the most important difference. The most important that in electrical burns, the cardiac rhythm and the cardiac muscle could have been damaged. So we need to practice EKGs and monitor the cardiac rhythm of client with electrical burns because the electricity could produce myocardial damage and can produce alteration of the cardiac rhythm. So this is what makes special the electrical burns. And the other component of the burns is that when mm, hydrocarbons are burned, okay? And hydrocarbons is anything that is plastic, anything, and the world is full of hydrocarbons, no? When hydrocarbons are burned, a substance called carbon monoxide is produced. Sorry. This substance produces a modification, an abnormality in the hemoglobin, and then the hemoglobin is able to uptake oxygen in the lung while passing inside the lungs, through the lungs, but then the hemoglobin doesn't release the oxygen to the cells, to the tissues. So the hemoglobin becomes incompetent or greedy with the oxygen and then is not releasing the oxygen to the tissues. As a consequence of that, the tissues becomes hypoxic, and then anaerobic metabolism is initiated. Lactic acidosis can occur, and then the client can have multiple organ dysfunction and can die as a consequence of the carbon monoxide intoxication. A peculiarity of the carbon monoxide intoxication is that the skin have a weird, extreme red color. The normal skin, the skin that has not been burned, has a red color, a cherry red color that is not more than the very saturated hemoglobin with oxygen, because as you remember, the hemoglobin is not giving away, is not releasing, is not giving the tissues the oxygen that the tissues need. It is treated, eliminating the inhalation of carbon monoxide and giving oxygen 100%. Frequently, the clients that have burns could have compartment syndrome. For that reason, you know that this dark charred tissue that occurs in the full thickness burns tends to shrink, and especially if the burns is circumferential, can produce a strangling, it strangles the circulation and can produce compartment syndrome. For that reason, doctors need to do a what is called sclerotomy, um, sclerotomy, which is the incision to allow the pressure to be released and to allow the patient to have the adequate circulation. Let's see this other question. The nurse cares the client arrive with burns 20%. The calculation Parkland formula is 2,400 milliliters of fluid in the first 24 hours. What volume had the client received after the first 3 hours of fluid replacement? So how you do this calculation? Very simple. Half this volume, so 1,200, need to be passing in 8 hours. So it is going to be 125. Let me see. 1200 divided by 8 is 150. It is going to be 150 milliliters per hour. Yes. And they are asking you in the first 3 hours. Yes. So if each hour you are having 150, in 3 hours you're going to have how much? 400 and 50. 300, 450
450.
and 50. So you mark this. So there are different uh, arithmetic calculation applying the Parkland formula. Make sense? No problem with this, yes? We can advance.
Yes.
Okay. Any question? No.
A question, Professor, do we need to know anything about a skin transplant or something like that or no?
As I said before, it's to specialize. The most important for you is the one that requires a skin graft is the full thickness. That requires a previous prolonged period of wound care to produce the adequate granulation tissue that is going to fill the burns areas. And now when the granulation tissue is ready, is when taking taken from the sparse parts of the body that have not been burned. A superficial layer of skin is taken and is put over the granulation tissue as an auto graft. Meanwhile, the granulation tissue is in this process. They can use cadaver, other people, no? Cadaver or animals. Okay, uh, transient skin graft to protect the tissue, but those are not going to be permanent, of course, are going to be rejected. So this is the most important. Once the skin graft is done, is kept with a bulky dressing, the main enemy, the two enemies, the two enemies of the skin graft are one, edema, and second, movement. So the skin graft need to be immobilized because movement will move, okay, the cells from the contact with the granulation tissue and never will grow roots into the granulation tissue. And edema will also kill the grafted cells. That's what elevation and immobilizations are critical in the skin graft. Um, when they use animals, meanwhile, to cover the tissue, it's called xenograft. And when they use cadaver, it's called allograft, okay? And when it is the definitive, the one that is going to grow is going to be called, okay, autograft. This is the theory that you should know about that. But as I said, I never seen question about that. I don't been informed of questions so specialized because, as I said, remember, they say that what is NCLEX? Entry level generalist nursing. I know everything can be in NCLEX, but what is important, entry level generalist knowledge. So what is the importance here? A new graduate nurse that is receiving in the ER a burn client and is aware that A and B of ABCs is the priority to determine the client has been burned in the face. This is a common question. And it's a question you cannot fail. Because if you fail this question, evidently you don't have any idea of how to care a client with burns. Okay? And the next priority is the circulation, the capillary leak syndrome, and the hypovolemia. Yes. And everything that we have been commenting, it could be. And then you can have, okay, complications like this, hyperkalemia, myoglobinuria, acute renal failure, GI bleeding. That could be in a scenario in a clinical case, in the case study that you can have, okay, a client with burns is perfectly a good candidate, where they are going to ask you for the signs and symptoms, then they are going to ask you to make a prioritization, where there is an excellent scenario to make prioritizations. Then what kind of indication you expect from the nursing process, assessment, diagnose, interventions, and then evaluation at the end. How you know the patient is responding to the fluids, is going to have urinary output more than 30, etc. So remember that what we're doing at this moment in the bootcamp is making a refresh of the content, okay, a review of the content, the basic. But it's impossible to to cover everything. But the most important should be review, and I think this is the most important. Based in what is in the Nclex test plan, what has been classically tested in Nclex, that people make comments. I had that question. I had that question. I had that question. And what is in the book. So those are the examples. Those details, the neck, for example, have been with certain frequency. So now you are guerra avisada no mata soldado. You are advised, you are warned about the detail of the head and the neck. Then the characteristic of the depth, the way that they ask the question, that is basically applying mathematics to the Arclam formula, but also those big little details. Okay. Frostbite behave like a burn. Why we are studying frostbite in Miami, because it is a federal test, and then frostbite behave like a burn. In the case of frostbite, they are a double injury. One is the thermical injury produced by the cold. Cold can freeze the cells and form crystals inside the cells that kill the cells. So produces necrosis. But then there is another component of the frostbite that you need to understand, because it's the question in English. The frostbite is made worse because an extreme, exaggerated vasoconstriction occurs in the digital digits is fingers, no? In the terminal circulation of the fingers. Fingers have an artery that ends there. And comparison with the arteries in other part of the body that have collaterals, have communication, have friends, have a community. Here is just one and end. Those are called terminal circulation. Is like no outlet, okay, street, no? And for that reason, the vasospasm is going to make worse the necrosis. So an important component of the treatment of this vasospasm is to vasodilate the extremely constricted digital arteries, So summarizing, providing warmth, okay, warmth to the extremities of the client that arrive with a frostbite is important. The way of doing this.
Sorry, what is the difference between frostbite and Raynaud disease?
Okay, it's a big difference. In Raynaud disease, this shouldn't happen. In Raynaud disease, the client has vasospasm, okay, a repetitive vasospasm. So a client with Raynaud disease will have the phenomenon multiple times, many times. So a person that have a Raynaud disease, just a moment, okay, Raynaud syndrome or disease, no, I don't know. Yeah. I want you to see that and you understand, because it's a good question. It's a question that can clarify. Okay. A person that have a Raynaud disease or Raynaud syndrome will have first, okay, a vasospasm in the terminal arteries of the digits of the fingers. And then the first phase, you see the fingers white without blood, okay? you see the fingers white without blood. Yeah. But then after some minutes, the fingers become purple because, had been prolonged. So now the amount of redox hemoglobin cyanosis produce, okay, this purpura. But then after that, the fingers return to vasodilation and the pink color return. So this is recurrent. It is repetitive. It occurs hundreds of times. You understand? And usually in Raynaud, there is not necrosis. So the vasospasm is not so prolonged as to produce death of the tissues, because once the tissues start having the cyanosis, immediately there is a reaction of the own tissue producing um, nitric oxide, a substance that is produced by the own endothelium, and then vasodilation occurs. So there is a sequence of normal hand exposition to the cold or to stress, then paleness, then cyanosis, and then the clients return to pink again. And it can repeat many times per day or all the life. Okay. Nevertheless, there is one form of Raynaud, okay, a phenomenon that occurs in a disease called scleroderma. So the Raynaud can occur in a normal person without any kind of disease. It's called Raynaud syndrome or Raynaud phenomenon. Raynaud disease or Raynaud phenomenon. Yes? But can also occur in people with diseases. One of the diseases in which the Raynaud phenomenon can occur is scleroderma. In scleroderma, not because the Raynaud, but because the scleroderma, you can guess scleroderma. Hence. Then in scleroderma, a part of the Raynaud, that you can have the Raynaud phenomenon, with the pass of time, you can have necrosis of the tip. A ver si consigo una buena foto. Or the tip of the fingers. Not all the clients, no. I have good pictures in my PowerPoints, but not here. Okay, so sadly, but you can have necrosis in the tip of the fingers, but it's a chronic necrosis. It's a progressive reabsorption of the tip of the fingers, okay? So the tip of the fingers are reabsorbed. And then it's because it is the only one that you can have necrosis, that you can see the necrosis in the tip of the finger, but it's chronic, recurrent along years, okay? It's not an acute condition. So what is the difference of frostbite? That you go to Alaska in January, and God forbid you are lost in the snow, and then your poor fingers, okay, becomes like ischemic, and then you have this severe okay, burns in your fingers. The most classical affected are the toes, but can occur. The toes are the classical, the one that suffer the frostbite. So all those people that that have practiced those sports of mountaineers, okay, those are people that likes to climb mountains. I don't know for what, okay, just for the fact that the mountains are there. Frequently, they don't have toes. They have the toes amputated. This is the most common form of frostbite. But what I wanted to, for test purposes, I wanted to tell you is that an intervention, mira para este que severo, an intervention in frostbite is that you have an injury and necrosis in the that can be stopped, okay? There are degrees of frostbite, okay? Can be stopped before reaching this severe necrosis if you rewarm the extremities, and then you produce vasodilation, and then you save a lot of tissue. And that's why it's important that a rewarm is the intervention in frostbite. Okay, and then you have a lesser degree of frostbite, and then you rewarm the extremity, the blood circulation is reestablished, you see a reactive erythema, hyperemia, and a lot of pain. When the circulation is reestablished, a lot of pain, you know, and that's it. Don't massage. You know that I just seeing here, okay, somebody doing this. Don't. This is a question in Nclex. Don't massage. Caca, no. Don't massage. This is going to produce more injury. Okay, the massage of the skin, either in pressure ulcer, burns, or any of those conditions, will produce more trauma, or more injury. You see that even you have blisters, but then they can recover, okay, because it's a second degree. It is the frostbite. Okay, of course you never see that in Miami, but that's it. This is frostbite. And the question that had been in about frostbite, if you are aware that it is a condition that requires rewarming, and how you do the rewarming with warm water or moist compresses. So you can submerge the hands in warm water in this range of temperature, or you can cover with gauze or compresses soaked with warm water, warm normal saline. And don't forget that it's requiring opioid analgesic, because when the vasodilation returns, it's going to be very, very painful. Compartment syndrome can occur, and of course, after that, uh, doctor will do a surgical debridement of the necrotic tissues, and sometimes amputation if it is rewarmed early enough before the necrosis occurs. I mean, in a second or third degree of frostbite, you are saving a lot of tissue, because what is interesting and different in the tissue injury in frostbite compared with burns, with thermal burns, is that the vasoconstriction make it worse. Is clear now?
Yes, yes. Thank you, Professor.
Okay. Pressure also have a lot of questions in English. You know that pressure ulcers are the consequences of pressure, friction, shear, maceration, and malnutrition. And these parameters that are the causes of pressure ulcer are all evaluated by the Braden's risk assessment scale. Interesting, no? Moisture, sensory activity, mobility, nutrition, friction, shear, those parameters that are the cause of pressure ulcers are evaluated by the Braden scale. That is the most commonly used instrument to assess when a nurse admits a client, to determine if the client requires a special interventions to avoid pressure ulcers that are 100% responsibility of the nurse, or if it's not necessary. So you don't need to memorize the breathing scales, but you need to know that it's called breathing scales. And you need to know that it's an assessment instrument that tells you, oh, this patient doesn't have risk of pressure ulcer, or oh, this patient has, yes, risk for pressure ulcer. I need to start interventions to prevent the pressure ulcers. So they are going to explore the sensory, the patient is conscious or not, the patient feels, because it's very important. If you don't feel your butt, then you can be sitting hours and hours, and the butts are, are in fire, and you don't feel anything. Moisture, the incontinence produces maceration. The maceration of the skins is what happens with your fingers when you are spending too many hours in the swimming pool. Eh, At least in your childhood, you did that, yes? And you saw how your fingers, the skin in your fingers become white and wrinkled. This is something benign when you are in the swimming pool, but if it is a permanent moisture in the genital or sacral area, because incontinence, it is going to produce a skin breakdown. The incontinence, a part of the moisture, is going to produce aggression by the chemicals of the urine and the feces. Activity, if you move, you don't have risk. If you are, bed fast or wheelchair fast, then you have risk. The same for mobility, and nutrition. Nutrition is an important component of the pressure ulcers. And nutrition is mainly evaluated with the level of albumin, the main protein of the blood, to have an idea how nutrition is evaluating. The presence of friction or shear in a patient on bed or in wheelchair is also evaluated. So you are giving points depending of the presence or absence of each one of these. What is interesting in braiding scale that the score is inverse, proportionally inverse with the risk. So the lower the score, the higher the risk. Any score less than 12 is a high risk. Usually a normal person is un 2, 3, 4, 5 por 4, 20 más 3 es 23. So usually a normal person like you and me have a score 23. 23, no, 28, sorry. Ya estamos 1, 2, 3, 4, 5, 6, 4, 20. No, sí, 23, 23. Sorry, 23 is the maximum. So you and me are 23. So we don't have risk of pressure also. They don't need to do any special intervention. But then you admit a person that have 2 here, 1 here, 3, 2 here, is 5, 2 here is 7, 1 here it is 8, and 1 here is 9. It's a very high risk. So that client is not enough to tell the CNA to turn the client every 2 hours. Every 2 hours is too much time. So this client must be moved more frequent. So maybe because I decided to be very poor nutrition, I need to make a consult with the dietitian. And I don't, I gave one. So probably because the client's constantly moist because incontinence, and because it has such a high risk, maybe doctors order a Foley. And maybe because the client has this risk, the insurance approve a mattress that is continuously moving. You understand? So could be an air mattress, a fluidified surface mattress, or a water mattress, whatever. But because changing the position every 2 hours to this client is not enough. It's going to develop the pressure ulcer. So don't think that changing position the clients every 2 hours is enough. Sometimes, many times, it's not enough. And it's an education that you need to acquire. Probably you are going to be trained after working in sites in this how you decide intervention. But the interventions are going to depend of the scale, the braiding scale, the score that the clients get. So pressure, what is pressure? You know that in some parts of the body we have bony prominences. So touch your elbow, touch your sacrum, touch your heel, touch your back of the shoulder. You have a lot of protruding bones there. Yes, those are called bony prominences. And what you have there is a skin and bone. You practically don't have fat there, and you don't have muscles there in those bony prominences. Those areas in which the bone is protruding in the skin without cushion, without this cushion, if the client is supporting the weight in those bony prominences, then a necrosis of the skin is going to be produced. Because if you have, ¿y por qué yo no estoy en, ya va un segundito, record from. So if you have here a bony prominence, okay, if you have here a bony prominence, yes, you have here a bony prominence, and here you have a blood vessel that irrigate this part of the skin. So now you are resting over this bony prominence and you have sensation problems. Maybe you have diabetes, polyneuropathy, or the client has, paraplegia. Yes, the skin is weak because the skin has no good nutrition and is macerated. And then you have the pressure of the bony prominence. The pressure of this bony prominence will cut the circulation. So what is going to be the consequence after a while? That all the skin without circulation and a skin that is weak will develop necrosis. And now you have necrosis of the skin. And now you have a pressure ulcer. But friction is the friction that makes the skin against the mattress, the surface that where the skin is supported. So suppose that this client this is the mattress, yes, and this is the skin. So of course you need to turn the client, okay, up. Okay, so trying to turn in your minds the clients in this direction, yes. So suppose that the client is resting in a mattress and the client is sliding frequently in the mattress, yes. So the skin is scraped, is a friction against the mattress, and this can damage the skin. This is friction. You know when occurs a lot of friction? When the client must have elevation of the head of the bed for issues, for problems at risk of aspiration, bad respiration, etc. And then, of course, the weight of the client is going to pull the client in this direction. So the body slides downwards, yes? And then friction occurs between the skin, especially the sacral skin and the mattress while sliding down. And now comes the two CNAs hold the client in each arm and pull the client up because it's sliding down in the mattress. But then when they pull the clients up, it's going to scrape again the skin against the mattress. Once is not going to happen anything, but many times during the day, along many days, is going to produce an accumulated trauma that predispose the client to a skin breakdown because of friction. It's important to teach the CNAs to use the draw sheet. You know, these sheet that we put under the client to to lift and move, not to pull and slide against the mattress. The shear is the same process. The shear occurs because the the skin is going to be attached to the mattress, no? And then the skin is like a stick to the mattress. But the weight of the body is mainly represented by the bones, by the muscle, by the center of the body. So the body is moving in this direction while the skin is kept in this direction. It is a tearing movement of the skin that also promote, okay, a skin breakdown. So avoid elevating too much the head of the bed for long period of time because it produces a lot of shearing. The maceration, is the moisture of the skin. And you know that the pee-pee and the poo-poo burns the skin. produces skin breakdown. Malnutrition that is measured with albumin also produces a bad quality of skin that is easily broken. The staging of the pressure ulcer is important. There are 4 stages. The 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 ya un momentico. No. Sorry, un segundito. Ya, este sí funciona. The first stage, the skin is not broken. The skin is continuous, but is red. There is a red skin, erythema. Well, we can have erythema in the skin. If you see the palm of your hand, you have erythema, or we have erythema in the palm of your hands. But if you make pressure in the palm, you see how it blanch. It becomes without, the place where you make the pressure is blanching. You can remove the blood from the skin. There's blanching, it's called. Okay, when there is a deep injury, okay, because has been supporting pressure for too long, this erythema is not going to blanch. So it's a non-blanching erythema. It is already considered an ulcer. Even if the skin is continuous, you don't see a skin breakdown, you don't see a hole, it is already considered, is classified an stage 1 pressure ulcer. And I noticed that it's difficult to accept that, but you need to learn to accept that it is already a pressure ulcer. If you make a biopsy of the tissues in the bottom, they are dead cells. They are already dead cells, and that's why the hyperemia, the hypercirculation, that is not blanching, because there is an inflammation there. This is a very weak skin. This is a skin that, if the factors are not removed, is going to break. For that reason, in wound care, when there is an stage 1, they of course, they remove the friction, they remove the shear, the pressure, maceration, all those risk factors need to be removed. But then this area is covered, is covered with a dressing. It's called transparent dressing. Is like a film, is like see, a film, okay, a plastic that attaches to the skin. This is a biofilm that allows the skin to breathe. You understand? But is a barrier, is a layer, is a film that is protecting this susceptible skin. And it is Nclex question, how is treated an stage 1 with transparent dressing to protect the skin until rehealing the stage 1. No problem, ¿verdad? It's easy to understand, yeah? Stage 1. Okay. Stage 2 is when you have a partial thickness, okay, lesion. So now you see a hole, you see a skin breakdown, but is superficial, is a very shallow ulceration, very superficial, affecting only part of the skin. So only the epidermis and the superficial part of the dermis is dead as a consequence of the pressure. This kind of wound is considered stage 2, is seen more or less like this. You see a superficial erosion or a shallow ulceration of the skin, but in the bottom of this lesion, you see skin. This is dermis. This is dermis. What has been lost is the epidermis and the superficial dermis. So it's very similar to this that we studied recently. Yes, the partial thickness burn. In this case, in the case of the pressure ulcer, understand that is this rubbing against the mattress. It is rubbing, has friction against the mattress. So this how you call this, roof of the blister is easily or quickly broken, and the liquid is spilled. So what you see is the ulceration, because this blister quickly breaks when rubbing against the mattress. But the initial, you can see that in some cases. You can see sometimes the blister. Sometimes you can catch the ulcer early enough when the blister was already present. Make sense? But the problem is that this blister is against the mattress, yes, and rubbing the mattress, yes, and quickly break. So you don't see the blister. This little skin that you see here probably is the roof of the blister that was covering this stage 2 pressure ulcer. These stage 2 pressure ulcers are very dry, no moisture, yes? And you need to learn that when the lesions, the skin lesions are dry, they don't heal. Dry don't heal. Need to be kept moist. That's why never a pressure ulcer is left uncovered, is never left exposed to the air. Yeah, never. And need to be all time covered to keep the moisture of the tissues in place. But because this skin tends to be very dry.
Professor?
Yes.
Only one question is short. You say that never, even stage 1, never be without
left with a dressing. What I say about stage 1, you need to cover with a
yeah.
transparent dressing.
Okay, perfect. Thank you.
And but especially this should never be left dry, because the air will dry the tissue that is here, and now the remaining skin, the living skin will die. Yes. So that's why you need to cover that with a dressing. But the dressing that is used in this kind of superficial dry ulcers is a dressing that give water, moisture to the wound, to the tissues. And then those are characterized by the word hydro, hydrogel, hydrocolloid, hydro. What is hydro? Hydration. Yes, hydro is water. Hydrogel, hydrocolloid. Yes, has the capacity, the dressing, of providing moisture if needed by this stuff that you are seeing there in the picture, to keep it moist. Makes sense? So when you see hydrogel, hydrocolloid, when they are used in dry lesions, like this one, so you expect that a stage 2 to be dry, Usually it's dry. Makes sense? So you are going to have a gel, like a gelatin, if you know, a film or layer, a sheet of gelatin with water that is applied here over this to cover, soothe, keep the temperature, keep the moisture, over this. No problem with that. There is. So when you see those hydro, okay, are the function of this. If the nurse is slow to diagnose the problems and the pressure, the maceration, the shearing, the malnutrition, and other gather, and then you have a loss of all the skin. So you have a full is all the skin and killing all the skin. Yes, all the skin, full thickness. But the depth of the ulcer stop in the subcutaneous. This is a stage 3. Stage 3 is a full thickness lesion. All the skin is gone, but the depth, the hole stops in the subcutaneous. This is what defines stage 3. So you are going to see a lesion where you notice that the epidermis is the one that has the melanocytes, the superficial dermis, and the epidermis has the melanocyte. So this black person, the epidermis is gone. But then you have the dermis. The dermis is always pink. You understand? Because in this deep dermis, you don't have melanocytes. So always the dermis is pink. Okay. And so you are going to see that all the skin is gone. So now you see what is a full thickness. Now you understand what is all the skin is gone. You see that? But then what you see in the bottom is the yellowish, okay, tissue that is in the under the skin, that is the subcutaneous. You don't see muscle. You don't see muscle. Why you don't see muscle? Because you are the ulcer, the hole stops in the subcutaneous. Why you don't see muscle? Because to see muscle, you need to go deeper. So it's so easy. It's so easy. The treatment of this level, it depends. If it is dry, they use hydrogels. If it is too secreting, we'll use the same that is used in the most deeper that are always very secreting. So there are material for wounds that are very productive of secretion. So there are some wounds that produce a lot, a lot of secretion. If a lot of secretion is produced by the ulcer, because it's deeper, because there is more inflammation, whatever, then this liquid that is produced, this produce maceration of the surrounding still alive tissues and make the ulcer bigger. So when there is secretion, it's a very, moist, a lot of secretion, ulcer, something should be placed there to absorb this excess of moisture. The best is not gas. No, it's not the dry gas. No, gas. No. It's something called alginate and some other form of foams and alginate. You need to learn that. You know why it's called alginate? Because initially, before being produced synthetically, it was extracted from algae, the sea algae, no? Algae, no? Alginate. These foams and the alginates are dressings that are very dry, and where they are placed there in the hole, packing the hole will stop the fluid, separating the fluid from the tissues, forming like a gelatin that separates the fluid from the tissues. Another good alternative to those very secreting deep ulcers would be the wound vacuum, the negative pressure wound care. Yes, the wound back that I want to explain later. Okay, so now you know what is the alginate and when is produced. Borré todo el hueco y ahora me va a costar trabajo hacer el hueco. Okay, so if the stage 3 is dry, hydrocolloid is a good alternative. If the stage 3 is very secreting, alginate or wound back could be an alternative. In stage 3, I erase all my whole, but you try to imagine that in stage 3, the depth of the ulcer reaches the muscle. Once the ulcer reaches the muscle, even the most superficial layer of the muscle, it is already stage 4. Once the ulcer reaches a muscle, yes, you don't need to reach the bone. You don't need to reach the bone. Because I know that some professors saying, when you reach the bone, you stage 4, of course. But even before reaching the bone, when you reach the muscle, that's why I try to make you remember anatomy and physiology, the layers, and the order of the layers of the soft tissues. Once the wound reaches the bone, the muscle, it is a stage 4. Of course, from there can reach not only the bone, can reach China, okay? But it's still a stage 4, stage 4, stage 4, stage 4. There is no more than a stage 4. And understand that this staging is done first at the moment of admission. First is done only at the moment of admission. Yes? And as far as you are able to see until which depth is reaching the ulcer. So the ulcer need to be already free of necrotic tissues that prevent you from seeing the bottom. Make sense? Okay. And if you see the ulcer until the bottom, then you can make a staging and at the moment of admission. Maybe later this ulcer start healing and you see how the granulation tissue will start healing, covering that. Well, this is still a stage 4, even if the ulcer now is very superficial because has been healing, is now very superficial, is a stage and is still an stage 4 in the process of healing. And when there is no ulcer, is an stage 4 already healed. Okay, so is the terminology that has been accepted for those pressure ulcers. As I said before, if the ulcer is covered by a tissue that prevents you from seeing how deep the ulcer is reaching, you can't stage the ulcer, and you say the ulcer is for until now stageable. When the doctors remove, okay, with sharp debridement, this eschar, okay, and you can see how deep the ulcer reaches, then you can stage the ulcer after it is removed. The stage 4, as you see the muscle. This is muscle. This stuff that you see here is muscle. So it's in a stage 4. Usually stage 4 tend to be very secreting. So a lot of secretion, like this slough that you see here. And that's why it's very beneficial to use the alginate or the negative pressure wound treatment. In the negative pressure wound treatment, the hole, the cavity, is filled with a foam, espuma, goma, sterile foam. And then after the wound is packed with this foam, you need to cover the foam with a tightly apply plastic adhesive sticky dressing. This is connected with a tube that go to a pump that sucks. So need to be connected to the electricity, no? That sucks and has a canister that collects all the fluids that are sucked from there. And Nclex question is what happens if you notice that this sponge, this foam is bulging. So instead of being sunken, you see the bulging. This foam, because it's under suction, is under negative pressure, should be flat, or even sunken. If it is bulging, it means that the vacuum, the negative pressure has been lost. For that reason, it's bulging. And it's because probably this transparent dressing that you can see here is not well attached to the skin and air is entering. So you need to remove all this and repack again and apply a new plastic adhesive on a sticky transparent dressing to reestablish the negative pressure in the womb bag. That's it. This is what you need to know about that. Don't forget that clients with pressure also, the same as burns, etc., requires protein, vitamin C, and zinc to potentiate the healing. Don't forget the breathing scale, the breathing scoring. This is an example. This is an example of a very, very common pressure ulcer, the heel. People that are very sick, okay, and are bed-bound or are on bed for a long period of time, they have their lower extremity resting more or less, okay, with this shape, okay. And then most of the pressure is exerted in the heel against the mattress. The heel is an example of bony prominence, that you have only skin and bone. And is very susceptible to, because it's an area that generally have no excellent circulation, to suffer necrosis. And then you see that the clients develop those necrosis usually with this skin that is totally dead, scar covering the ulcer. By the way, this scar is not removed; is left there as far as not infected. Is left there because if we remove the doctors, it's a doctor's decision, but it's a comment that doctors don't remove this specifically heel eschar, because if they remove the eschar, the bone is going to be left exposed and will suffer necrosis. So they'll wait until the granulation cover the bone and the eschar is released spontaneously. How we avoid this from happening? We need to place ¿cómo se llama? A pillow not under the knee, but under a pillow here, You understand? A roll here. Never under the knee. Remember that under the knee produce DVT. Here is very super. The deep vein that produces the deep vein thrombosis is very superficial in the popliteal area that is behind the knee. Behind the knee. Yes. So we never place here pressure because it promotes DVT. Here is a no. But then we put here, yes, a roll here under the ankle and the legs. So the heel is never touching the mattress, is floating in the air. It's a common question in the English, by the way. And those were the topics that I wanted to discuss with you about exit, about integumentary. Save. There is another short topics that I want to comment with you. I don't know if you already been, because there are some people that have been for a while, assisting to do some boot camps, some people that are not. Another topic that is short and can be quickly covered, okay, is breast cancer, is cancer in general.
I have a question, Professor.
Sure, go ahead.
I had a question like regarding burn, and then they were asking me what kind of fluid. I mean, what do I do? This patient had a burn, like 60% body burn, and then the choices were normal saline, um, immunization for tetanus, and then monitor the urine output. And I don't remember.
Based in those options, I would need to see the question, because this is not about what fluid you are using. You are about what you do first, or what
Yeah,
you.
yeah. The
Okay,
question was like,
so you
which.
need to understand the question. If the priorities are A, B, C's, and they are giving you, I don't know, assess the airway, it is the first. But if they don't mention the airway or the lungs, and they mention fluid for the C of circulation, it is going to be the next priority, and then you can wait for giving the tetanus immunizations or the pain medication after you go through the priorities. You understand? So I need to see the question to be able to understand that question.
Thank you.
Professor,
Yes.
the normal, like I'm sorry, we would give lactated ringers for burn patients, correct?
We prefer to give lactated ringer to the
Mhm.
burns clients. Is the fluid of choice, with the exception of a client with hyperkalemia or high potassium, or a client with renal failure, in which lactated ringer is contraindicated because contains potassium. In that case, we use normal saline. The majority of the clients with burns don't have hyperkalemia or renal failure, only a minority. So most of clients with burns will receive lactated ringer. All rules have exceptions. And the exception of this rule is that if the client has high potassium or renal failure, then they don't receive lactated ringer. They receive normal saline instead. But they are the minority. They are the exception of the rule. Now is understood?
Yes, thank you.
Okay.
Understand. Thank you.
Okay. Okay.
Professor,
Yes.
before you pass to breast cancer, I have a question. When you are prioritization questions about burns, what percent of burn that we consider like a black tag?
Can you repeat again because I couldn't understand
Yes.
the question. Can you repeat?
Okay, at what percent of the burn that we can consider the patient like a black tag? It's related with prioritization when you can choose what patient to see first or not.
So the priority in burns
Yeah.
will be always the airway. Don't make it complicated. Don't make it complicated. Bet no more than $1, but bet that at least 10 of you will have the classical question that which client you see first. The client has cinch beard, cinch eyebrows, cinch nasal hair, or a client that have dry hacking cough with hoarseness, you know? Because it's the burns of the airway. This is the priority. In question of prioritization, this is the priority, the A and B's of ABCs. And the next priority is the circulation. Sadly, pain must wait for A, B, and C. Pain is important, but needs to wait for the stabilization of A, the stabilization of B, which is breathing. A is airway, stridor, etc., hoarseness, etc. B, breathing, low oxygen, monoxide intoxication, presence of wheezing, crackles, pulmonary edema, and circulation. Circulation is an extensive burn with hypotension, decreased urinary output, etc., etc. So those are the priority, and then comes pain. And then very, very, very posteriorly comes the infections, comes the deformities, contractions, and rehabilitations, and the skin graft. I don't know if it helps you to anticipate how it's going to be the prioritization in case of burns, no? Or no? Tell me.
Not exactly that. That was a question.
What is the doubt that stays on you?
For example, if I see a patient that has 80% of burn or 50% of burn or
You
60%,
say, oh, you are
I
talking
say,
about
yeah, at
ruling
what,
out,
yeah,
assigning a black tag
yeah, that tag,
should
yeah,
be the death angel that will decide that somebody is not worthy of expending resources and time in the client because the probability of recovery is very low. Okay, forget it. You will not have this question in your English. It's evident that an entry level new graduated nurse is not competent enough as to decide if a person that has more than 80% of the body surface area burned doesn't deserve to live, and resources should not be wasted in this client. Your common sense and your critical thinking will be enough to understand that any program, any test, any English can make a new graduate nurse to assume this responsibility. Forget it. You will not have this question in your English. I know the test banks, the ATI, the HESI make you take those decisions. They are wrong. You are not qualified to take this decision. The test that you will have in NCLEX, we are here preparing you for NCLEX. And the NCLEX that you will have will not make you take this decision. In United States, patients with 80% of the body surface area burns have been saved. And you are not the one that will, take the chance of this person of surviving. Did I explain myself?
Yes, very well.
Okay. So forget, don't worry. This question will not be in your English. I know that have been in your test, but you are not going to be doing this kind of triage. You are not going to be the angel of death. You need to die. You can survive. I decided that because I'm a very, powerful, okay, angel. No, forget it. This is not an ankle question. Sorry, my philosophy in preparation for English is very radical and sometimes is not orthodox because I consider that sometimes we prepare you for stuff that are not needed to pass the English. You understand? That's why I insist. I insist in make you go deeper in important stuff and not in this not no frequent test, no frequent questions in English. English is a very smart test. I defend English as a very smart test. Those guys that makes question in English first is not only one person, it's a team of people. So they discuss the question between several people. And they have very good experts there. They have everything there. They have pharmacists, they have doctors, they have nurses with a lot of experience, and very smart people. It is a high level. Forget Beijing, forget MRU, forget not even forget this level. It's a very high level in United States of an institution making very smart question, okay? And questions that are practical, are real life questions, are questions that are going to present you a human being in which you can help, at the level that you can help, okay? And they are going to test you if you know what you need to help. So expect more the question of the airways, the circulation, etc., than this horrible question that I see in test bank that is a very unfair question. Guys, let me advance a little about cancer because I want to cover this review that with you because it's an important topic. Breast cancer, please learn these risk factors for breast cancer. They love to make questions about risk factors for cancer, specific cancers. But you know that breast cancer is the number one because it's the most common in women. So breast cancer, the main risk factor is to be a woman. This is the main risk factor, but this is stupid, So it's stupid, it's not going to be tested, but it's the main risk factor. If you are a man, you are less afraid of breast cancer than a woman, okay? It's very rare in men. Second, aging. This is important. The older a woman is, the higher the risk. The risk increases significantly in general population. Don't bring those special cases that have very strong family, risk factor. I'm talking about general population. The risk starts around 40 and becomes maximum after 50. But the older that you are, the higher the risk. This risk never stops into increasing. That's why an older woman has more risk than a younger woman. The other risk factor is genetics. There is a super important genetic influence in breast cancer. So there are genes that predispose some people, some women, to breast cancer more than others. It doesn't mean that always they are going to have breast cancer, but they are increased risk because the cancer is a combination of genetic predisposition, areas of the body that are more delicate in some people than others, plus environmental, triggers or environmental factors that combine with this genetic predisposition make much more possible the appearance of this cancer. So family history is super important, but must be family history in first degree. And it's a detail that you need to incorporate, some of you. First degree is mama, is sister, and is daughter. Yeah, because it's a cancer of women. First degree relative is having the mother, having a, ¿cómo se llama? A sister or daughter with breast cancer. So if we have the woman X, and this woman has the mother, the sister, or the daughter with breast cancer, then this woman has increased risk of also developing breast cancer. When we talk about this genetic predisposition, the worst predisposition is demonstrating inheritance of these oncogenes. Oncogenes are certain genes that are inherited that make especially susceptible or weak parts of the body to develop cancer. And this BRCA1 and 2, or BRCA1, BRCA2, also known as Angelina Jolie gene, because Angelina Jolie inherited this gene, and she decided to have a bilateral mastectomy and bilateral ovarectomy. So she removed her ovaries, no? Because these inheritance. And it doesn't mean that is the indication, but it's a famous stuff that many people know. So this is the worst scenario in genetics. So if a part of having a first degree relative with breast cancer, if they demonstrate that the woman that we are investigating, you remember the woman that had the daughter, the sister, or the mother, if we discover in this woman through a test, because can be tested, BRCA1 or BRCA2, this is the highest genetic risk. Again, no 100% is not mandatory that is going to have cancer, but the risk is huge. The probability is huge. Another point that you need to have in mind for test purposes, for NCLEX purposes, that if you have a family member, I mean, woman X, mother, sister, daughter. If you have a family member that developed the breast cancer at early age, this is worse. I mean, if you have a woman X that her mother developed breast cancer when her mother was 70, and we have woman Y that her mother developed breast cancer when she was 50, woman Y has higher risk than woman X. Why? Because the relative developed the cancer at earlier age, which translates that the predisposition, the genetic predisposition is stronger. You know, the woman that has the cancer at 70, well, the older that you are, the higher the risk of cancer. But the woman that had the cancer in her 50s is giving a strong genetic influence to why the daughter. Makes sense? So the younger the relative, the worse the genetic risk. It has been tested. It has been tested. Okay, let me explore if you understood my explanation. Which of the following female clients has the highest risk for breast cancer? 30 years old, active runner. Okay, it is a distractor. What is important here is 30 years old. It's very rare, extremely rare breast cancer at 30 years. So you can rule out that. 40-year-old with twins. It is a distractor. It's not the most important. 40 years, the risk starts, but it's younger than these two. So we can rule out that. Now we have 45 years old. Now, more age, more risk. With a 21-year-old child, and mother had breast cancer at 65. And a 55-year-old with two kids and sister had breast cancer at 35. So which has the highest, C or D?
D as in David.
It's D as in baby.
Exactly. So, okay, this is a reproduction by me of an actual English question where you are applying the explanation that I gave you. Age is important. This is older than this. And then the age in which the family member developed the cancer is also important. So the mother of C had cancer when she was 65, but the sister of D had the cancer when she was 35. So the genetic predisposition of this poor sister is very strong because she developed cancer very young. And this is the same genetic predisposition or her sibling, her sister. So this woman is a very high risk. So it's a woman that requires what? And very careful surveillance. How? With mammography. Makes sense? Okay. And then come some risk factors that can be modified. Alcohol and tobacco. Because you cannot modify that you are growing older. You cannot modify that you are a woman. Well, now we cannot talk about that because it's a very polemic topic. But you cannot modify that you are born ¿cuándo empiezo? Woman. You cannot modify your family, even if you want. Okay, I want to be okay, you know, a relative, a millionaire, but I'm not. I'm relative of only poor people. Okay, so you cannot modify your family, and you cannot modify your age or gender or family, but you can modify smoking and drinking. So drinking and smoking are important risk factors and can be eliminated. For that reason, are frequently tested. So what you can do for a woman that is older, has family members, etc., you can educate the woman of the importance of the mammography, the annual mammography, etc., etc. But you can do a lot for a woman that is smoking or drinking alcohol. The other risk factor that can be modified is obesity. Obesity is a risk factor that can be modified. Guys, the adipose tissue produces estrogen. For that reason, obese women have more risk of cancer in those genital female areas and those in those females body parts that respond to the estrogen, breast, uterus, ovaries, etc. So obesity is an important risk factor of those females cancers. Okay, there are other risk factors that are of lower significance, of a lower possibility of testing. Early menarche before 12, late menopause. Remember that when you are a girl, okay, and you have not yet, started menstruating, you don't produce estrogens. You start producing estrogens when you develop your menarche. If you start producing estrogen when you are 9, in comparison with others that start producing estrogen when she was 14. And then the other is late menopause, and then you stop producing estrogen when you are 58, and she stopped producing estrogen when she was 48. Yes. So now you have ¿cuánto? 49, 18, sí, 49. You have 49 years receiving estrogens, and this is going to have 34 years. ¿Sí? 4, 8, sí. Yes, receiving estrogens. So early menarche, yes, late menopause are refactor. Why? Look at this example. This girl started, menstruating at 9 and stopped menstruating at 58. So she was exposed 49 years to estrogens. This girl, this is normal, started menstruating at 14 and stopped at 48, only 34. So it's a big difference. 15 years, okay, more receiving estrogens. This is it no critical, but it is a risk factor. Early menarche, late menopause. Sometimes women, okay, receive after menopause hormonal replacement therapy with estrogens. This is a prolongation of the exposition of the breast to estrogens, and this is something that increases the risk of breast cancer. In the past, in my time when I was a student and I was, dealing many years ago, we used to tell all women after menopause, hey, start taking estrogens so you don't have the hot flashes and you keep your youth. Until the science discovered that these estrogens after menopause increased the risk of breast cancer. And then we stopped recommending that to all women. And if it is needed, because the woman is very symptomatic, are given for very short period of time. So receiving hormonal replacement therapy increases the risk of breast cancer. Obesity is tightly related with diabetes, so there is a connection between type 2 diabetes and obesity. It is interesting. Having babies or becoming pregnant before 30 statistically has demonstrated to be a protection risk factor, protective factor, not risk factor, protective factor. Not having children, so being nullipara, or having the first child after 30 is a risk factor. Other, less common seeing risk factor having dense breast. There are women that has very dense breast in the mammography. It is associated with risk factor. Not important. I don't think it's going to be in your test. Is history of chest radiation or being in, I don't know, in atomic bomb explosions, etc. Radiation always increases risk for any cancer. Previous history of breast cancer. If you have cancer in your right breast, you have increased risk of having cancer in your remaining breast, of course. Summarizing, pregnancy and breastfeeding are protective. And very important, those stuff that young women suffer a lot, like the fibrocystic breast, those lumpy breast, before and during menopause, yes, perdón, menstruation. I'm repeating, was distracted. I say disparate. I said some nonsense. Those lumpy breast that becomes very symptomatic, painful during menstruation, before and during menstruation, are not risk for breast cancer. The fibroadenoma and the fibrocystic breast disease are not risk factor for breast cancer. Usually are mentioned in the English as distractor. Don't click on there, click on the other. Remember that the screening is the mammography. For the mammography, the question is don't use talc, body talc, body powder, or deodorant. And the mammography is done in a menstruating woman, should be done after the menstruation, 1 week after the menstruation, when the breasts are deflated or are less tender. In relation with the breast self-examination, I haven't seen questions about this in a long time. Probably any of you were my students. I used to bring the updated research about breast self-examination and the polemic, the discussion about this. That's why I don't think it's going to be in your test. But if the breast is examined, should be examined 1 week after the menstruation. Is done monthly at the patient preference, but 1 week after menstruation. What can be tested, had been tested, in which quadrant of the breast is more frequent to find tumors of cancer, and is in the superior or upper outer quadrant or superior external quadrant. If, for example, it is the right breast, yes, this is the armpit, this is the arm, right arm. So if it is the right breast, you divide the breast in 4 quadrants, the and outer, upper and outer quadrant is the one that have breast cancer most commonly. The second part of the breast that have in second order most cancer is retro. Okay, retro is behind the areola. You know what is the areola, no? The nipple and the areola is the second place. It is have been tested. You know that when there is breast cancer, they do chemo and radiation, but they do a mastectomy. The mastectomy can be more or less aggressive, but a consequence, the frequent consequence of the mastectomy is the lymphedema, because they need to remove lymph node of the armpit. They make classical question on lymphedema, very easy question. Lymphedema is treated keeping the arms above the level of the heart. So using the gravity force to promote the reabsorption of the liquid of the swollen arm. And they use stockinets. Stockinets are like sleeve that are compressive, the same as those stocking or hoses that we studied to prevent DVT in the lower extremity, but are placed here, okay, to prevent. Exercise is good. Nclex question. Exercise and range of motion is super good for lymphedema. You need to exercise for lymphedema. Okay, so for example, tennis, ping pong, how you call this, canoeing, roar, no? ¿Qué se dice regata en inglés? Sí, roar.
Rowing.
Roaring. Okay,
No,
roaring.
rowing.
Perfecto. Those are being in English are good. And even, doing this exercise that you put your hand against the wall and then you crawl up the wall with the fingers until extending totally the shoulder. People that have lymphedema, should avoid blood pressure taking in this arm, should avoid blood drawn in this arm for blood test. I could check down there. Should avoid activities that promote skin injuries, like for example, gardening, like for example, cutting the nails with scissors. The nail should be filed, okay, but not cut, etc. Because little wounds in the skin will promote worsening of the lymphedema. Okay, so this is the most important. When you see when you see this picture, okay, that looks like the skin of an orange because the dimples that make the pores, it is the most severe, the most severe form, the most advanced form of cancer. It's called pudrange, okay? A skin of orange, yes? And this is the lymphatic infiltration of all the breast is the most advanced form of cancer. Cancer frequently produces a new onset retraction of the nipple and dimple in the skin. Okay. The breast cancer, a part of the chemo and radiotherapy that are topics that we'll discuss later of this chapter, frequently uses a medication called tamoxifen. Tamoxifen, you know that a woman, a woman, okay, a woman has, okay, estrogen receptors all over the body. Has estrogen receptor in the breast, has estrogen receptors in the brain, in the hair, in the skin, in the veins, in the bones, all over. That's why women are different from men. You see, the skin of a woman is different from the skin of a man. The hair of a woman is different from the hair of a man. Of course, we don't. Let's not talk about the breast and whatever. No. So you have all over your body, okay, estrogen receptors. Uh, there are medications that stimulate the estrogen receptors in some part of the body, but block estrogen receptors in other parts of the body. For example, tamoxifen blocks the estrogen receptor in the breast, which is good because estrogens, if you have cancer in your breast or you had cancer in your breast and you receive estrogen in your breast, cancer can reappear or can reappear or can extend. So it's good to block the estrogen receptor in the breast. In clients that had breast cancer with estrogen receptors, not need to be a cancer with estrogen receptor. But at the same time, these estrogen receptors blockers could stimulate estrogen receptors in other parts of the body. So also blocks estrogen receptors in the vascular system in the brain and can produce also hot flashes, induce hot flashes. And but can stimulate the estrogen receptors that have to do with the veins of the legs and the coagulability, and for that reason increases the risk of DVT. So the client that is taking tamoxifen is avoiding a new breast cancer, but could be suffering of hot flashes, which is annoying, but also could be at higher risk. Higher risk doesn't mean that need to have necessarily, but is at higher risk of developing DVT. For that reason, a question like this, client taking tamoxifen, which client complaint require follow-up, you go to the serious one. Dyspareunia, that is having discomfort during sex, night sweats, and headaches are not the most important, but calf tenderness, subjectivity, and that's why the answer of this question is C, as an example of question related with tamoxifen. Okay, in the next class, we'll continue talking about other cancers that are very important. Okay, so I just wanted to take advantage of this 15 minutes that were left to gain time. Any other question, guys?
No, professor, thank
No,
you.
professor, no question. Everything clear.
Thank you.